announcements.
Let me make sure you can share. Perfect. Okay. Do you want me to share the agenda as we go through it, or are you going to do that?
I can do it.
Perfect. You should be good to share.
Welcome, everyone. My agenda says my job is to welcome updates and announcements. I'm gonna give everybody 1 more minute to get logged on. And I'd really like in the welcome for us to, if we can, put on our cameras and introduce ourselves again, just so we can all continue to kind of know who all's here and kind of where we're from and what we're hoping to do today. All right. Well, so just so everybody knows, I'm not Kim. Obviously, Kim is in DC, being extra special, and so she asked me to lead the meeting today, and I agreed. So I really appreciate everyone being here. I think this is such an important group, and there's such great work happening in the state right now, and I'm really glad that everybody takes the time to come together and talk about this really important issue. So just so everybody knows, if you don't, my name is Tisha Dean. I am a psychologist by training. I work at UAMS as the Director of Behavioral Health Integration, and I have worked in integrated care for pretty much my whole career, and did a lot of work at the VA. And so my real getting my feet wet in integrated care was is their model that they do, and they do a PCBH where you have integrated behavioral health providers inside the clinics, and then they also have collaborative care where you have prescribing providers and care managers. And so really the way that my brain sees integrated care is with both types available, and so we've really been working hard to integrate collaborative care into our clinics at UAMS. We have mostly integrated providers, but we did not have the real prescribing consultation piece. And so that's what we've really been working on. And so my involvement has been with this group as number one, working with Dr. Hudson in creating the grant for the SAMHSA grant, or submitting the SAMHSA grant with DHS, and also being an advocate for collaborative care in Arkansas. As you know, our UAMS sees a lot of patients with Medicaid, and so if we're not able to pay for collaborative care through Medicaid, it's not going to be a sustainable able to be sustainable in Arkansas, or at least at UAMS. So I have a lot of vested interest in us being able to do this. So I'd love for those of us who are here to introduce ourselves.
Tisha, I'll go ahead and jump in because I'm eating my tuna fish salad, and I will be off camera doing that because y'all don't need to see that. But my name is Mark Jansen. I'm Vice President, Chief Medical Officer of Arkansas Blue Cross Blue Shield. For 29 and a half years, I was a primary care physician down in Arkadelphia, Arkansas, and so saw firsthand in the trenches all the behavioral health opportunities that were there. Felt like I did a pretty good job in that space as far as taking care of folks, but always was looking for more help than I had, both from a referral standpoint as well as an in the moment consultation to, to work with folks who had those problems, because pretty much everybody I saw had some problem. So I appreciated how common it was. Then left there to come back home to Little Rock in 13. I was at UAMS for 6 years, ended up being the chief medical officer for regional programs. And so Tisha's path and mine kind of crossed a little bit, sort of, and that we were really understanding the criticality of putting licensed clinical social workers to offer further behavioral health services embedded in our clinics and not stuck in a closet down the hall, but rather frontline where they could be readily available and keep an ear on what was going on so they could speak up if there was a BH issue that a resident or a faculty physician was dealing with. And then since 19, I've been at Blue Cross, so I'm in my 5th year as CMO here. Thank you.
Thank you. You such a wealth of experience and a great perspective. It's so, I feel like that sometimes in this integrated care space, I know in a lot of the meetings and stuff, it's very like mental health people involved, and the people who are doing the brunt of the work are our physicians and our primary care providers. So it's so great to have you here. Nicole?
Sure. Hi, team. My name is Nicole Portrude. I'm the Senior Program Manager with Mindula Health. I am personally located in Philadelphia, but we're all over the US as a remote provider of collaborative care in one of the states we serve, also serves this group here. So, my role as Senior Program Manager, so I handle a lot of the operations, helping to build workflows and processes in our program that help us to really serve as many patients as possible from as many locations as possible, and from as many different styles of patients as well, really be able to serve as many different diagnoses, populations, age groups, and really trying to define what that care looks like in our service as well. So I'm really happy to be a part of this group.
And
Cover everything.
Bree?
Hi, everyone. I'm sick, so pardon my voice here, but I'm Bree. I oversee collaborative care for Mercy across the ministry. So I'm in Missouri, Arkansas, and Oklahoma.
Thanks. And Julie?
Hi there, I'm Julie Carmen. I'm a nurse practitioner and family practice and psych certified. I work at Boston Mountain, and we serve uninsured, underinsured, and insured patients Northwest and North Central Arkansas.
And Mary Beth, are you able to introduce yourself? I see that you don't have video, so.
I do not have video. I don't have my camera plugged in. I had to rearrange my office because my windows are broke. So I'm not all techy today, but just know I look fabulous today. But I'm Mary Beth. I'm with the Arkansas Academy of Family Physicians. So I'm here to tie in our family physicians into collaborative care, and just appreciate the great job you all have done and keep doing.
Great. And then I think everyone but Caitlin has gone. And Caitlin, you want to introduce yourself just so everybody knows who you are?
Sure. I'm sure you guys have seen my face all over ABEN stuff, but I am a project manager for ABEN. I am an LCSW by training, and I have spent the last 10 years or so of my career doing integrated health, and mostly in Central Arkansas. And it's just very nice to hear the passion and support from everyone, because boots on the ground, you can get a little discouraged sometimes because you don't get to have these conversations. You're out there and you're doing the work. You don't get to come together with a lot of other people to have that conversation. So I do have to give a shout out too. I heard Dr. Jansen speak at the Rural Health Conference not last week. I'm really not sure what even date it is. And I heard he is recovering from a hip replacement. And I've heard from several people that he does not stop. So I just want to give you props for making it all the way out there. And yes, We were all everyone I sat with was very impressed at you sharing that. So just glad that you're here and excited about our conversation today. Tisha, I don't think David introduced himself. I know he jumped on.
Okay, yeah. David?
Yes, I'm David Jones. I'm an LCSW. I am one of the assistant directors of the Office of Substance Abuse and Mental Health here at DHS, OSAM. And I am the project director of the SAMHSA grant that we have going on with UAMS.
Great. Well, glad we have such great representation nationally and all over the state. And also I love that we have, such a wide array of professions too, of nurse practitioners and primary care and psychology and social work. And it's just, I love how this topic brings people together. So the next thing on the agenda was for me to update on the executive committee meetings. There have been 2 executive committee meetings, and for the most part, they've been kind of just structural and people introducing and getting to know each other. We've got some subcommittees working on the evaluation pieces and just kind of looking at the implementation, and I think sustainability is going to be moved to the state planning commission group. So there's going to be 3 committees: the implementation, evaluation, and then the state planning group. And I think most of the conversation in the last meeting was focused around some questions about from SAMHSA about the informed consent, and there's some questions about whether patients would have to sign informed consents to engage in treatment with the providers that are going to be funded by the grant. I have voiced my opinion that I did not think that would be a great idea, because we have to have informed verbal consent, and it has to be documented in the chart for people to get enrolled and to engage in CoCM for it to be billed. But adding an additional informed consent where you have to sign it could be a barrier to patients actually engaging. I know we have some very hesitant patients anyway, and so telling them, that they have to sign this in order to get involved, I think could be a barrier. If, for the evaluation piece, there will have to likely be a signed consent for us to get their data. And so, I think we just have to think really strategically about how to get that information and get them to sign those, with them understanding that they can say no to their data and still say yes to care. So, and that the signature, and what the data entails. It's a little, I don't know, I think that we need to have, or those who are managing the grant need to have some conversations with SAMHSA about what they really are wanting, and why, because I think that the IRB is going to say that this isn't human subjects research. We are implementing a program that is evidence-based. There's not any risk to the patient as far as we are giving them an intervention that we don't know if it's effective or not. We know it's effective. So the only risks really would be confidentiality, if they can be identified. So that was the biggest conversation that's been going on. The other thing is working through contracts. I hope that I don't know about Boston Mountain, but I hope that we've been in ABIN, hope that we've been able to get those contracts working through the system. But that was another thing. Any questions or discussion around the executive committee meeting, my update?
I don't have any questions, but I do want to echo your thoughts related to like verbal consent versus written consent. In my experience, patients do tend to have a hesitancy, and like any opportunity for additional opt-out is not always in that best interest, though having that consent. I know we've identified workarounds where we get that consent from the primary care provider or for the referring provider, and then also the management team will also then echo that verbal consent just to ensure that we double down and have it, and that there is that like verbal buy-in and that it's well documented on our end and exists in the chart. But I don't know how effective or efficient at getting a written consent. I also think it's a barrier for a lot of our patients that wouldn't have access to, I mean, I guess it depends if this would be like an in-person or a remote model, but that there's a lot of barriers I could think of in person and remote in regards to being able to read and write and all of that related to that. And then also on top of it, if it's a remote environment, having access to technology that permits you to sign. So there's a lot of things that run into my head, and it feels like a really big obstacle to accessing care.
Yeah.
So I have two questions, and I'm going to be really vulnerable here, so just bear with me. My first question is, don't primary care patients have to sign a yearly consent form anyways, to get care from that office? First question is, do we not have them do a yearly consent with CoCM because it's so individualized? Some patients will need it, some patients may not. Or could we fit it into the yearly consent? Is that something we could say, this is a service that we provide in this office? If you need it, that would be it. I'm just curious on if that would fit into that or not, or is that not good practice?
For CSM billing,
Mhm.
the consent has to be like given by the primary care provider, and it has to be documented in the chart during the visit that they talk.
Individually, okay.
Yes,
Okay.
it's not a consent to treat, wide ranging consent to treat. It's related to this. And whenever they, I mean, another advocacy piece, there has been lots of people advocating on the CMS side to do away with this, or to allow any of the care team to do the consent, so that again, you don't kind of have this need for like a specific thing to happen in this one chart at this one time,
Right.
which dictates all of the rest of the care. But right now, the way that it's worded or the way that it's done is that way. And this is a specific, and this is different from the SAMHSA grant is wanting consent for them to engage in treatment related to the grant. And
Right.
so and the data collection. And
Mhm.
so there is specific data that SAMHSA wants. Whenever the grant was being written, it was believed that this would not be human subject research. We're not going to have a in-person specific informed consent, but now that's being brought up by SAMHSA that we may have to. So that's another piece of it, like to use the data to collect to give to SAMHSA.
That makes sense. That was my second
Okay,
question, so
and
I'm glad you
Caitlin,
answered that.
just going
Dr.
back to my
Jensen?
practice days, I don't recall when I was in practice that patients I saw on a regular basis were having to annually consent for me to continue to see them.
Mhm.
In fact, I'm not even sure that they had to sign anything. Usually the paperwork that was done had to do with assignments and billing and things of that sort. But I know in the emergency room, there's always been this thing called implied consent. If you
Right.
show up for care in the ER, you are consenting to the care because you showed up for the care. And so I don't know if that's how it works in a private office at this point, or are there new regulations requiring annual consent for treatment. I do know that the whole issue of mental health is at a whole different level as far as records, release of records, things of that sort. So there may be some additional requirements as related to mental health therapy over and above the typical run-of-the-mill physical health that a primary care physician would see in the office. Just don't know about that, but annual renewals of consent to be seen. Don't recall that at all.
Gotcha. Okay. Thank you so much. And this, I'm so glad that, thank you both for answering that question, because when people go back to watch this, I'm sure they'll need some extra information too. So I really appreciate you guys explaining that.
Yeah. So and David, do you have any updates or any input on this, just from the DHS/SAMHSA point of view? I didn't know.
Not really. I do know SAMHSA apparently is starting to review the forms that we turned in October of last year. And so there may be some additional changes coming down the pike as they process through those forms. Paul and I have been having internal discussions about, on the state side, basically, once we get a framework of what collaborative care looks like in Arkansas, we have already discussed kind of what we will need to do on the state side to start getting it going and rolling through the process of promulgation and CMS and getting it a paid service. And as I think I've mentioned almost in every meeting, we're not waiting till at the end of the 5th year to start this process. So we're basically all we need or waiting for is a framework. What does it look like in Arkansas? And then we will start on our end to try to get it going.
Great. Thank you, David. And yeah, and thanks for that piece of information. That's one of the things I missed out. That's kind of how this conversation is starting, is that SAMHSA is starting to go through the documents that we sent in October. And so this is one of the sticking points or the questions or concerns that they had. So as we're just working through things with SAMHSA. And also, David, I would love to maybe talk with you and Paula at some point, because we have some pretty good data and some good information about how it's working at UAMS right now, because we do have a clinic that's been going for a couple of years now, almost, in Batesville, and we're in internal medicine, and we're about to roll out in Pine Bluff. So we've got some information that may be helpful to you. And
that would be great.
Mercy too.
Yeah.
I think Mercy's been going for a long time, so they've got some good data too.
Yeah, that would be great. We would love to do a meeting.
Awesome. Well, the next thing on the agenda is Caitlin with local and national updates.
So that is typically Dr. Gibson's section. So I sent her a nice text message this morning and said, what would you like me to communicate to our friends? And she kind of is just echoing everything that you guys are saying. It just wanted to communicate that obviously CoCM is a very hot topic, very active topic right now on a national stage. We talked about this last meeting, but with like upcoming events, CFHA is going to have that virtual conference, and obviously they're going to have a lot of opportunity to learn about CoCM and different interventions. And then they're also doing a that in-person one in San Antonio in October, I believe. So she just wanted me to remind everyone about that, and just kind of reiterate the fact that everyone's kind of struggling with this, or maybe not necessarily struggling, but like contemplating problem solving, trying to figure out how they want to do that in their health system. She says that paying for CoCM and BHI is still one of the biggest barriers to implementation. That's not a new concept to us. And trying to figure out financial sustainability is just one of the biggest barriers. So just kind of looking at payer sources and seeing what everyone's able to do is kind of the next step. So she just wanted to reiterate that everyone is having these issues, and which brings up the point is why we're having these meetings and having this conversation. So.
Awesome. The next agenda item, and you may have already done this, David, was updates from DHS.
Yeah, I think that was our update. We are really excited about this SAMHSA grant and where it will go, and so we're really excited about this.
Welcome, Verna. How are you?
Good. How are you? Sorry, I was arguing about collaborative care codes someplace else. So apologies.
sounds like it's a thing that happens a lot these days.
It sure does.
Bye, Dr. Jansen. Thank you for your input today. So
Sorry, I'm bugging out. I've got another meeting I've got to run at 12:30. Thank y'all.
bye. So the next thing on the agenda is me and updates from UAMS. I started those a little bit. So as far as the SAMHSA grant goes, we are hopefully in the very last stages of getting our collaborative care, our care manager positions posted. I just got a rather unsettling email about it, so hopefully I can get it figured out. We are trying to hire them to where that we don't have the requirement that they have to have they have to be a licensed mental health professional, just for sustainability of pay, and also because everyone on this call knows how hard it is to hire licensed mental health professionals right now. And we have a bunch of licensed mental health professionals. We need people who can help in supportive ways. But I just got an email saying, oh, they got approved as non-LCSWs, so we need to change it to LCSW. So I don't know. So that's where we are right now. We are also working on the Epic build for the registry, and we have a project that has been approved, and I am right now harassing people to try to get a project manager approved to that on that project. But in the meantime, I have last year I did the training to be a physician builder in Epic, so I've been doing some things behind the scenes to hopefully speed that process along once I can get people with a little bit more IT permission to move things over to production. So that's another thing that we are working on. Also have some materials that we've worked on as far as kind of educational, understanding the different roles for the different team members. We have I had a little bit left over from another grant, and so we are bringing in the Dr. Ratzliff and Monica Harris to do a site visit for us and do some training. So that will be in the beginning of April. We're very excited about that. I think that's really going to help us to have them lay eyes on our clinics and give us some good ideas and feedback on how we can keep the process going. We also have implemented, we've started in Pine Bluff, and we have our second psychiatric consultant. His name is Jonathan Chastain. He's an IT fellow, but also a psychiatrist who has done collaborative care in Florida, and he is glorious and wonderful. And so we have him for a half a day a week, and we're really excited about him. Any questions about how we are moving along at UAMS? We're a little bit ahead of time. I was really curious about our other team members and kind of what you're doing on the collaborative care front, like how things are going with your programs. Anybody would love to share, or wouldn't love to, but would be willing to.
I think for us, it's we've been doing CoCM and CCM and for a while now, but it's kind of like I feel like we've almost, like in anticipation of all this, we've almost like pulled back some, and I don't think that's good necessarily, but it's kind of like there's just so much like, okay, do we want to start anything new, or do we want to, or do we want to wait? Just, so it's kind of that in suspense right now. And that's kind of the way it feels. And I don't really like it, but it's kind of like, well, what else do you do at this point? Just kind of working out a few things, making sure we're prepared and have, meeting with the billing and, just the different groups. So I guess we're not really in as much suspense as it feels like, but I'm ready to like get going. And so I think there's kind of like that moment of, that's kind of where we're at.
I'm happy to jump in next. There's a couple of common themes that, on an ongoing basis, just really ensuring that providers have a strong understanding of the services that we offer and understand the billing concept and, are verbally describing at the beginning of the process what collaborative care is in an accurate manner that sets us up for success so that we don't get a month into the process and the patient's like, hey, where's my therapist? And we're like, well, bad news. So there's a lot of, great provider education and focus in that lane. I think scalability is a huge part of the conversation on our end as well. I kind of feel, Julie, what you were kind of talking about, kind of like that feeling of like almost like needs to like pause and pull back a little bit, and really just taking a look at what we need to do to really be able to grow. With all of this need that we see out there, we just want to make sure that we're able to, one, bring in those patients and get them here, and then also be able to answer that volume of patients in an efficient and effective manner. So really just looking at that. And I think that has a lot to do with the registry, how it's built, the data that we're looking at, the way we're training people has been a huge topic of conversation. Even just the people that we're hiring too. One thing that we've been looking at is what regions are we hiring people in to make sure that like the amount you can pay a collaborative care manager is something that makes sense with the people we're bringing in. So we have that sustainability, so we don't have that high turnover. 1,000 things are coming up. So there's a lot to do. I feel like, I don't know if anybody else has that feeling that there's a lot going on and it's kind of just trying to pull it all in and pick the direction you start at and kind of working towards that scalability. So I feel like that's been a big theme lately.
And until which places in Arkansas are you working with?
I believe Baptist Health is the larger partner. We may have another one that is escaping my memory in this moment, but Baptist is one of our bigger partners. Hattie brought me into these conversations, and then she left. Well, she's not gone, but she's not here today.
Abandoned us. I think she's also in DC.
Oh yeah. Oh well, she's close to me now. I should go visit.
No, she's actually, Dr. Gibson's actually at an award ceremony for her kiddo.
Oh,
And it's just me, I'm the only one left in DC. Megan's back here. You can't see her. She's another one of my coworkers, but Kim left us out here. So, but yes, Dr. Gibson's doing something really fun. So we'll excuse her this time. Yeah.
we'll give her permission.
Mhm.
How about Verna or anyone at Mercy? How are things going with Mercy?
I think the big problem at Mercy, I mean, we have, thousands of patients that we're caring for across their system right now. The big problem with Mercy is actually the codes and the ability in Arkansas. They have actually been paying to support the Medicaid patients, and that is becoming not sustainable. And, they're not part of the grant funding. And so it may be that the services to Medicaid patients as part of Mercy get discontinued because of the reimbursement.
And think this was before you got on, Verna, but we did. David from DHS had said that they were wanting to kind of get an idea of how things are working in Arkansas and kind of start the process of figuring out how to, what it takes to get the codes turned on. And I had talked about getting maybe us getting together and giving some data to them.
I can give you data on thousands of patients from 6 and up that we've cared for in Arkansas with outcomes, suicide reduction data, PHQ, GAD. Like I can give you all of that.
Yeah. And I was telling them we had some data too from UAMS, and we can get what you guys have for Boston Mountain and maybe pull that stuff together and we can get this process started.
I think we've cared for about 14,000 patients now in Mercy.
Great.
And probably the same in Baptist now, given the size of the system. So if we could put that data together, then that would be great.
Well, I'll be in touch because I think
Okay.
that is a very important next step.
Yep, glad to do it at any point. It takes me 10 minutes. I can run that data and get it right over to you.
Awesome. And I think David had mentioned that he's having issues with his headset, so he's not ignoring
I
it.
think it's
Oh, there he is.
fixed. Can you hear me? Okay,
Yes.
good.
Oh, we could. Now you're going.
Yeah. Came and went.
Oh yeah. Yeah, I was gonna say, yeah, the data is good, but we also were needing, as I said, the framework of how it's going to look, because we've seen the data that that it
Yeah.
does work. Collaborative care does.
So
But our process is, how do we turn, how does this look like in Arkansas into a Medicaid policy? And then, of course, we have to promulgate that through the legislature. And since we have not paid for this services, most likely we're going to have to change the state plan too, which will have to get approval by CMS. And so,
yeah. So two things. I have some other Medicaid, draft. I actually literally am just editing the Maryland Medicaid bulletin now. So we have others that we could share. And then there is a document coming out, and it'll come out any day. I can't share it. I had to sign something saying I wouldn't, but it actually further supports the cost reduction. That might actually be helpful for you. I can share it with Tisha and make sure that everybody on this call gets it, but I'd be glad to help you with any of that other Medicaid language. And we're working with the APA now to have a document that actually is meant to be a guidance for states and Medicaid directors and teams to be able to outline. So I'd be glad to share all of that with you, whatever would be helpful.
yeah, that would be great.
Great. Yeah, and I think maybe us, like maybe with Boston and with Mindula, and as kind of, I think if we can make it as Arkansas specific as possible and think, like this is how it's working and this is what we're doing and this is what we think, this should say, would be helpful.
Perfect.
Awesome.
Yeah. Yep.
Right.
And I think taking from the things we know have worked in other states, like where things have been tried and they didn't work and they had to change them. Like, I think what we're trying to do is let's save states the pain points of that, or at least share with them, this is why that didn't work in certain places. And, so that people can go in with that information.
Great. Other pieces of discussion, pain points, things that I was curious, Julie, who is doing the psychiatry or the consultation piece for you guys?
Well, it's kind of different, but we have a full-time psychiatrist, and then we have several psych NPs, and then we have LCSWs, so we have that are there. So what we usually do is we kind of have a rotation, because there'll be people that'll cancel appointments and different things like that, and then we have a few slots scattered throughout the day. So if the PCP needs a consult, then they usually will reach out to one of the care managers, and then the care managers will review the schedule and say, okay, who's available right now? And then that's who goes. So I know it seems like a very disorganized process, but the flow actually works for us.
And
how does that meet the collaborative care requirement for the psychiatric consultation? Or is that just if a provider needs a consult because they're seeing someone and needs a consult, but you have a separate process for the collaborative care consultation?
Right. And that's the thing that I feel like working with this is going to help us I feel like it's not as specific as it needs to be. And that's one area where I'm hoping that we can provide a little bit more specificity in, is just that, just having someone look over that and say, okay, this is where you really need to kind of further delineate to make that even more, you know.
And
Yeah.
are you guys
We
billing
might
right
have
now?
something to help you. I'm working with Laura
Okay.
Sidari on a document for organizations outlining like psychiatric consultation and meant to be a guide. And maybe we could share that and you could actually let us know if it's helpful or not, because that would be really good feedback.
That would be awesome. And I will tell you, like
Yeah.
a lot of stuff, we don't end up billing for it, you know, so there's a
Why
lot.
is that?
Um, that's a whole nother story. That's a really long conversation that maybe you and I should have at another time. But just with, you know, we have some people that are on a slide, they don't have insurance, they have, you know, like there's just all different things that we see. And so a lot of it, you know, is
We
not.
should go through that. I'd be glad to sit for a couple minutes and go through it. And there's a
Okay.
really nice example that FQHCs have done for the collaborative care where they've actually bundled it on their sliding fee scale that HRSA has approved. And so it could be that there might be some, I mean, if you ever feel like I could be helpful, just reach out and I'd
Absolutely.
be glad to share that with you or to
Okay.
go through the billing. Because I've worked with a lot of FQs in states where the codes aren't turned on. And so we've had to bill some non-threshold kinds of things and then use some of the codes to get the PPS rates and, you know, had to do some things a little bit differently. So I'd be glad to think that through with you, so that it's, you know, consistent to the model and still sustainable and feels good.
That would be awesome.
Yeah.
Great. Yeah. And that's, you know, that's part of the hope for this group and the support from the grant is that ABIN and this group will be able to pull together some really good resources that are Arkansas specific and helpful, and also be able to put together some trainings and also do some implementation support, because we're all in this together.
Yeah. For sure.
Is a wealth of information.
Well, yeah, I don't know about that, but I'm glad to share things like, you know, that are happening in other places and then you could make them specific, you know, to what would work for you.
And it's also definitely working. Well, what will work for you guys too, because you're here too.
We are, yes, we are there. And actually maybe expanding a little bit. And with my other organization, Zero Overdose, we've actually put in some large grants there to do some zero overdose work. So it may be I'm coming to visit you more often then.
Well, we definitely need it in Arkansas, so that will be.
Yeah, your numbers are off the charts.
It's terrible here.
They are off the charts, yeah.
And with this group and also with me, you know, if you see things legislatively that we need to do in Arkansas to make things easier or to have some policy changes, let us know.
One thing to think about, and I don't know where you guys are on this, you know, the state or the feds passed the HBAI codes to broader disciplines, and the states are adopting them at varying levels, but that actually is really helpful for integrated care. And so I don't know where you guys are with those codes. Also the interprofessional billing codes, particularly if, you know, collaborative care is not on your Medicaid fee schedule, those interprofessional billing codes could sometimes help with the consultation for our FQHC friends. They're not going to be a threshold visit, but they could actually be a source of revenue for others. But the HBAI codes passed as a threshold visit would be really helpful for this, for the FQHCs, and might make a huge difference. Depression is usually carved out, but you can finagle it somehow. And so I would think about what that, some of those changes, would be helpful to support this work as well.
Yeah, I'd have to look. I'm not sure about the HBAI codes for Medicaid, but for private payers, a lot of them do, I think, cover them, and we're looking at trying to get that process.
Yeah, cover them, but only for psychologists still. They haven't
Or they haven't
transitioned.
switched it.
They haven't, a lot of them haven't followed the federal change yet. I mean, granted, we're only in March, but a lot of them have not actually changed that yet. And so once the state Medicaid start to do it, the commercial plans will start to follow. But those are just some advocacy things I can think of that, would help.
Yeah, and that's something maybe with Blue Cross we could talk to. We had Dr. Jansen on, and Patty works for Blue Cross. We have some people in some of our insurance companies. Well, the last thing on our agenda was Caitlin is gonna give us some information on some upcoming CoCM events.
Okay, if you were on last month's meeting, it's going to be a little bit of that because February was such a short month, so there really hasn't been extra events announced that have come across my inbox. So if anybody has anything that I'm missing, let me know, but I'm going to share my screen real quick. Just two things. Just a reminder, we do have this CoCM webpage up on the ABIN website. It houses a lot of information, and we're adding to it. This is not kind of the final form for it, but we're working on it. Just wanted to remind you guys that if you want to go back and watch our meetings, or if you need to see the notes and don't want to go through the terrible search function of Outlook, you can go through the monthly meeting recordings, and it will be linked underneath these videos. But the big thing I wanted to bring our attention to is as far as like educational opportunities, our monthly webinars, we've had several of them on CoCM and just collaborative care. Of course, Verna herself is on there too. So, and we know she's also a wealth of knowledge. So, these are just some of the webinars that we have. The rest are going to be underneath the webinar tab, but these were specifically for CoCM. So that is available for review. And then again, our BHI conference, we're going to have several speakers on CoCM and peer specialist substance use disorder, crisis intervention. So just to remind you about that, we are actually excited to say we're actually coming up to our registration cap. We have almost 250 people registered. Now we know things happen, not everybody's going to be able to come, but we do have a cap on that. So if you haven't registered yet, somebody on your team that wants to come, it's free to attend, lunch and breakfast and free CEUs. So feel free to come. I think it's really what we want to do with this conference is obviously give educational opportunity, but we really want to reach a broader audience of people that are doing this integrated health and bring them together so we can network and we can put faces to names and we can create relationships with everyone. So we can work together and make this easier for everybody involved in the state. So those are mine. I know some others may have some events that are coming up that I haven't mentioned other than the CFHA stuff that I mentioned earlier. I knew that chat was going to be from Verna on there about an event. Oh my goodness, thank you. And I'll make sure I put that in Misty will put it in the notes.
Yeah, it's a virtual learning event for collaborative care and SMI. And so SAMHSA's sponsoring it.
Oh, that's wonderful. Okay.
So if people are interested in that.
We'll make sure we get that out. Perfect. That's what I had, Tisha.
Great. Well, we have about 9 minutes. I'm happy to give people some time back. Unless someone has something they wanted to make sure that we talked about or questions that we did not get to. Thank you, everyone, for being okay with it being me and not Kim. I'm not quite as cheery as she is, but
we love you just as much.
I was gonna say just as much.
Thank you guys so much. This was really helpful to me, and that we had some great information, and be in touch about trying to pull together some of that data and stuff for DHS so we can get this ball rolling.
Yeah, just let me know what you need, and I'm glad to pull it together.
Thank you.
Good to see everybody.
Bye.
Thanks. Bye-bye.